in which a rare disease was found to be the cause for a common everyday affliction. A 58-year-old female presented to her doctor's office complaining of having daily headaches, low back pain, and general malaise. Patient stated her symptoms had been going on for several months and had not improved with over-the-counter medications, including ibuprofen and Tylenol. During the physical exam, the patient was found to be hypertensive and was started on antihypertensive medications. Labs were ordered, including thyroid function, renin aldosterone levels, electrolyte levels, and urine analysis. A follow-up appointment was made for 2 weeks to reassess the patient's blood pressure and review her labs. Upon her return, the patient's blood pressure remained elevated despite compliance with medications. The patient's labs were reviewed and were essentially unremarkable. The patient's medications were adjusted and different classes of antihypertensives were used, and a follow-up appointment was made for 2 weeks. Upon her return the second time, the patient's blood pressure remained elevated. At this time, secondary causes for hypertension were considered. A renal ultrasound was ordered to assess for renal artery stenosis, and this revealed a 60 to 99% stenosis of the right renal artery. A follow-up CT angiogram was obtained to further assess these findings. On obtaining this result, renal ultrasound initially showed stenosis. However, the CT angiogram did not reveal any stenosis. However, it did reveal the patient to have a thin enhancing mass in the left retroperitoneum, separate from the adrenal gland and kidneys, and this measured 2.4 by 1.6 centimeters. Discussions with the patient was had, and she was informed of the likelihood of a neuroendocrine tumor, and a decision was made to obtain a biopsy. The biopsy result revealed a ganglioneuroma. 2 months from the initial presentation, the patient had a robotic-assisted resection of the left retroperitoneal mass. The pathology for this was consistent with a composite ganglioneuroma/a neuroblastoma with positive margins. Nuclear medicine imaging obtained at that time revealed increased tracer uptake in T9, L3, and L4 vertebral bodies, which confirmed suspicion for metastatic disease. The patient was stage 2A. Subsequent to her surgery, the patient had two hospitalizations due to one for sepsis and two for uncontrolled hypertension and electrolyte abnormalities. On her second hospitalization, the patient was found to have catecholamine levels twice normal for norepinephrine, however normal for epinephrine and dopamine. The patient was offered palliative chemotherapy and radiation treatment. She completed her course and currently is without any symptoms and is found to be in remission, and follow-up imaging showed resolution of the T9, L3, and L4 vertebral body lesions previously seen. Neuroblastoma is a term used to describe tumors that arise from primitive sympathetic ganglion cells that have the capacity to synthesize and secrete catecholamines. Neuroblastoma, ganglioneuroblastoma, and ganglioneuroma are tumors of the sympathetic nervous system, collectively referred to as neuroblastic tumors. They are mainly found in the neck, posterior mediastinum, adrenal gland, retroperitoneum, and pelvis. Neuroblastoma is the most malignant tumor of the three. Hypertension is associated with intrarenal neuroblastoma with an incidence of 66 to 100% and is a rare condition. The patient's tumor was not located in the kidneys, yet causing treatment-resistant hypertension. If the basic workup for treatment-resistant hypertension is negative, don't forget to investigate malignant causes for hypertension, as was the case with this patient.